Good afternoon, everybody. We're going to go ahead and get started. We have two great speakers today. My name is Michael Dark. I am the manager for the Tobacco Control Resource Center here in Maryland. I'm also a clinical research manager in the Department of Family Medicine at the University of Maryland School of Medicine. So today we have two speakers talking about youth and adult tobacco use and treatment resources. I do have a couple housekeeping things to go over before we get started. I do want to say thank you to the Maryland Department of Health and the Center for Tobacco Prevention and Control, who, without them, we would not be able to bring you these webinars and the resources that we offer through the TCRC. So thank you to MDH. Just a couple things to go over. This meeting is being recorded. We do ask that you please remain on mute throughout the webinar. That way we don't have any issues with the sound. If you have questions, please enter them into the chat box and we will make sure to get to those during our session. Slides and recording will be made available on our website. I'll show you guys in a little bit where you can find those. But yeah, we will make those available through the website. We do ask that you please complete the evaluation at the end of the webinar. It helps us learn what we need to do differently, what you enjoyed. That way we can improve our sessions going forward. This QR code here will take you to that evaluation. I'll also place the evaluation link in the chat so you can click on it there directly. So with that being said, let me stop sharing here. So our first speaker is Dr. Panagis Galiotsatos. He received his medical degree from the University of Maryland School of Medicine, completed his residency at the Johns Hopkins Bayview Medical Center in Internal Medicine, and completed pulmonary and critical care training at NIH and Johns Hopkins Hospital. Panagis is an assistant professor at the Johns Hopkins School of Medicine, where he co-directs Medicine for the Greater Good and is the community engagement co-director for the Baltimore Breathe Center. His projects have impacted over 7,000 individuals in Baltimore City and over 150 healthcare professional learners. His research interests include chronic obstructive pulmonary disease, asthma, tobacco dependence, and health equity. So we are very excited to have Panagis with us today, and the floor is yours. I can bring up the slides unless you want to bring them up.
Oh, I can bring them up. I always feel like the awkward of next slide, please, is fascinating. So thank you so much for the introductions. Again, I know there's an angle for youth here, even though I'm going to present an adult patient case, but there's a significance why it all ties in to why we should pay attention right now to the youth epidemic of e-cigarette usage and other tobacco products. So without further ado, I'm going to bring up my slides. What I'm going to hopefully dive into the conversation. And Michael, can you just confirm presenter mode is on, slides are easily seen?
Yep, you're good to go.
All right. What I'm going to do, I'm a pulmonary and critical care doctor. I'm an associate professor in medicine and oncology. What I'm going to spend time doing is give you a little bit of insight of why having a dedicated clinical visit makes so much sense to manage this chronic disease, right? And what I hope you also take away is this is a chronic disease. There's a chronicity to this that simply a light switch going off does not occur in these patients. And hopefully I can really drive that point home with this these next few slides. So without further ado, I must make it clear that there's nothing really massively unique about us as human beings that other than maybe the cognitive stuff that can get philosophical, but from person to platypus and every mammal in between, we have a center of the brain that really conditions us to behaviors that it perceives as needed for survival. This was discovered by Dr. Pavlov back in the 60s. Dr. Pavlov, by the way, was a gastroenterologist. He was not a psychologist. He studied saliva, realized, hey, whenever you rang a bell, the dogs begin to salivate, expecting food. That's when he began to understand there's conditional responses that begin to occur when our brains are expecting a reward. And that reward, of course, should be centered on activities that our brain believes are needed for survival. That makes sense. We eat for that purpose. But the way we eat, if you think about it, it's kind of predictable. It's kind of patternized. And things may change here and there, but the overall concept stays the same. You all tend to eat in one certain place of the house, like a kitchen, and there's places you won't eat, like the bathroom, right? Your brain knows when to flip on that appetite, kick in the craving, so you can then begin to think, oh, this is when I should be eating. We are Pavlovian driven. We are conditioned to these responses, right? And even taking a snippet of that aspect, placing it somewhere else, can cue it in a little bit, right? You walk into a restaurant, you've never eaten there before, but you're getting hungry. There's aspects of it that resemble the kitchen. There's food. All your senses are being overloaded. The conditional response to eating kicks in, right? Even though this is a place you've never eaten before, suddenly you're feeling hungry. That's how we work. The actions that we recognize are needed for survival, our brain will hardwire us with contextual and internal responses to say, this is when you should be doing that action. And so conditional responses, it's the association between kind of independent stimuli that come together to drive that. And this is key for people who smoke. Because what happens with a chemically enhanced nicotine molecule is it takes over that part of the brain. It hijacks it from other drivers of survival. And if you sit down with a person who uses tobacco that produces this chemical of a chemically enhanced nicotine, ask them, when do you smoke? They might feel like pulling teeth because think about it in a different way. When did you eat yesterday? Again, you're like, I know I ate, but you don't put that much thought into it, right? It's not this consciousness that is stored and ready to retrieve from your brain. No, these actions that you do for survival, they're kind of on autopilot to some extent. You didn't sit here telling me how many bites you chewed before you swallowed. You can't really be precise with when you ate. You kind of have a foggy kind of estimate. See, but it's predictable. If you kept a food diary, you'd be like, oh, this is very predictable. Same thing here for patients who smoke, right? When they are like, oh, I do about a pack a day, that's 20 cigarettes. When do you do it? I don't know, doc. I think with my coffee, I think with eating. Here's a journal. Jot it down for the next month, mindfulness kicking in. And sure enough, they come back there and, wow, this is so predictable of how I smoke, right? Yeah. And so where this works in the part of the brain is called the mesolimbic cortical area. And this part of the brain, driven by sensory input from the prefrontal cortex, cues in what's called the ventral tegmental area, the VTA. Once the VTA gets stimulated with acetylcholine or chemicals that can hijack it because they resemble acetylcholine once they're chemically manipulated, talking about nicotine, then the bolus dopamine stimulates the nucleus accumbens, sends a signal up to the thalamus, and the person's happy. Thalamus is excited, it's done. But at the same time, it will form some new aberration of neurological connections governed through either Krebs or delta phosphate, these two proteins that say, hey, we need to make this into a memory. Same patterns that come again. I want to motivate you to do that action, such as smoking. And the mesolimbic dopaminergic system will create emotion, motivation, and memory around these actions. And not only create it, right, but in a manner that isn't fragile. This will be permanent creations. The way you ate as a child is very similar to how you eat as an adult. Yeah, maybe the kitchen's changed with a little bit of colors, but it's all the same. Meaning, the same way an adult also smokes, if you ask them, it's kind of the same way they smoked as a kid. Yeah, they may have hidden it here and there, but there's certain aspects to it that have remained the same. Now I smoke when I'm stressed. Did you smoke when you were stressed when you were a kid? Yeah, you bet I did. Smoke with my friends. Did you smoke with your friends when you were a kid? Of course I did. Same aspects here. And where it's established in the mesolimbic dopaminergic system, this is a powerful driver for mammals. And if you don't think it is, then why spend so much evolutionary time to well protect it, especially with circulation, right? This is a really established part of our brains. Now, this is also important to recognize because this part of the brain governs actions that you may not really, again, think of it. It's not a withdrawal. These patients aren't going through that, but they are going to get more motivated until it gets shut off. When the thalamus is picking up, though you have both intrinsic and contextual factors working in your favor to do an activity, it'll send a negative prediction feedback loop to the nucleus accumbens until it is rewarded. Now, if you're like, well, that's what goes in a person who smokes brain, sure. No, it also goes through your brain. Think about you being hungry. If your food is delayed, do you just forget your appetite and you're like, all right, life is good? No, you probably get angry, right? You probably get more motivated until that food is given to you, right? Because you're in the room where you eat, you see your favorite food, you see people enjoying the food, you're in a conversation, all of these forces working together for you to eat. And so there's an emotional response, there's motivation, all linked to a memory that is permanently established. So the mesolimbic cortical area of the brain goes through a lot of unique names, synonyms. Survival center is what I like to call it, but reward center as well as also other names it goes by. But the VTA is responsible for picking up all these kind of clues and being able to be activated by acetylcholine once an activity's been done, right? Acetylcholine through food stimulates the VTA, boluses the dopamine into the nucleus accumbens. Free-base nicotine, not just normal nicotine. So I apologize why it says nicotine resembles the structure. It is chemically manipulated nicotine. You need to knock off the methyl group. If you're an organic chemistry fan, nicotine in its natural form has a methyl group that kind of anchors it down, usually keeps its pharmacokinetics from being too expedited and an ability to have this effect, right? Free-base nicotine overcomes that. One way to think of this is a nicotine in its natural form, like you would find in eggplants, potatoes, tomatoes, it has a methyl group that anchors it. So think of it like a zombie that has, a missing leg. It's not going to get anywhere that fast. Free-base nicotine, much faster, can move at great speed. And of course, if you bolus it in with a cigarette, it's like having a million fast zombies attacking that area and will overcome and outcompete acetylcholine, hijacking those areas, and again, looking to form them permanently. So these are conditional responses that my patients reveal to me, because this is part of our strategy of helping them become non-smokers, is they have to understand their smoking phenotype in order to have it really established of this is how they're going to say, this is how they're going to choose how to unsmoke, right? Because that's the key strategy. I don't need them to say no to a cigarette. I need them to learn how to unsmoke, because the exploration here is, what did a cigarette mean to you for all of these responses? And some of them really could be very trivial, like, no, I just like it after coffee, it enhances my moment. But some of them are a lot more important. No, I smoke with anxiety. Okay. It means you fill the void of anxiety with smoking. You need to find a different activity, not to substitute the cigarette, but to replace it in a meaningful way that you can choose and recreate it day after day. So again, the nucleus accumbens, it generates motivation. And ultimately what happens here is it produces the main symptom of tobacco dependence around the addiction. What's that symptom? Ambivalence. What chest pain is to a myocardial infarction, what wheezing is to an asthma exacerbation, ambivalence is to a patient with tobacco dependence. They're living in this dual role of I want to stop and I don't want to stop. And that's not a fault of theirs. And you got to really redirect the conversation so they don't try to sabotage your planning with saying, I'm so weak. No, you're not. The person, the version of them that wants to smoke, there's nothing wrong with them. There isn't. Don't villainize that person, because you need that person. That's the person who tends to come out in very important situations to calm them down. It's the version of them during a flight or fight situation to create some anxiolytic properties during really heightened emotions. You need that person. Don't villainize them. They've just found a cigarette to fill that void for when the person needs it. You got to work with that individual. You got to work with that aspect of ambivalence. You have to have that understanding of these individuals. They enjoy smoking. That's the honest truth. Here's the other catch to all of this. As you'll see in this patient example, nicotine addiction is probably one of the weakest addictions out there by far. No one overdoses with it. No one withdraws from it. Well, very little, right? You don't hear about, oh my gosh, there was another cigarette overdose. No, that's not how this works. It's a very weak addiction. What makes it powerful is very similar to how you would describe gravity. Gravity is a very weak force. It is. It's the weakest of the four fundamental forces. You all will get up out of your chairs at some point, defeating gravity. But gravity is the strongest when it accumulates mass after mass after mass. You can get up off your chair, but you can't leap off this planet. Same conversation here. The average adult who comes to seek medical attention for the first time around smoking-related complications is about 60, give or take a few deviations. Their average age of initiating smoking is about 12. More than 80% of their life has almost been with a cigarette. That's gravity. You're not going to break that suddenly. The amount of rewiring that happened in the mesolimbic cortical area of the brain is outstanding. You can't break that. No amount of this is going to hurt you is going to fear-monger them out of it. So you have to be conscious that they will be living in an ambivalent state. Them coming to you saying, sure, I want to stop smoking. Yeah, it's like you walk into a doctor's office and like, yeah, I can lose this weight. Sure, this isn't where you eat. You have nothing driving you to eat here. Have that same conversation in the kitchen with your favorite food and everyone eating around you, and you're like, all right, maybe I can diet tomorrow, right? This is what happens when patients who are in the hospital like, I didn't really need a cigarette, right? This isn't where you smoke. None of this is telling your brain smoke. But once you get discharged and you get back into your car, it kicks in again. You want to smoke. So let's talk about a patient example for the last 12 minutes. Here's a 48-year-old patient I just had. And again, why this is so important to talk about an adult patient is because this you can extrapolate to the youth, but tackling the youth usage is going to prevent a new generation of patients. I can promise you that as a lung doctor. Chemicals in e-cigarettes and of course, combustible cigarettes, those are harmful to the lungs. So 48-year-old, she started smoking at the age of 14. And it's important to understand because you want to know the gravity of the situation. She's not coming to me with a year of just smoking. She's coming to me with the majority of her life being with a cigarette. And how has she been with a cigarette? Right? This is where then I begin to understand with her. Tell me how you smoke. I want to understand how you smoke, right? Because I'm not fear-mongering her. I'm not. Don't do that. Now, I've never had an adult patient come to me saying, this is bad for me. Yes, they know it's bad for you. This is the key thing that separates this addiction from other addictions. If you've ever had the opportunity to go to an AA meeting, you hear these people talk about traumatic events in their life and now they stop drinking. That's important to hold on to, but it's not what made them non-drinkers. They stopped drinking because they stopped going to places that reminded them of the usage. They didn't go to the bar. You don't hang out with Tom who drinks. But for people who smoke, the challenge is those contextual responses are all over the place. Their bar is the car. Their bar is their porch where they go and smoke. I mean, if you think about it, of all the addictions out there, cigarettes have been the only one that you could actually have a break for at work, right? You can go have a smoke break because it doesn't inebriate you. You go back to living, you're back at your job, life is good. So she began to tell me about her conditional response. The first clinic visit was kind of like pulling teeth. She went home, began her mindfulness journaling. She came back in 3 weeks and she goes, wow, she smokes 20 cigarettes a day. And what's fascinating is this is the patient. This is her. Those are the times she gets them done. Driving by far is her biggest motivator. She usually knocks off about 4 cigarettes between leaving home and getting to work and coming back. 4 cigarettes in the car. Then with food, she likes to have a cigarette with food. She didn't realize, she kind of knew it, but then she's like, wow, I'm very consistent. I tend to get an appetite for a cigarette the second I finish my meal while watching TV, especially if she's watching something that causes stress, right? Like the Orioles or the Ravens. On the phone with her friends. Weekends, when she's a social drinker, she likes to go out and smoke. Work breaks are a big one as well because she hangs out with people who smoke. Stressful times, happy times. These are such important understandings because what she's discovering is that the cigarette plays some role in these activities that heighten the activity and create an expectation in her. I mean, when she kicks in with mindfulness, she is massively impressed with how subconscious this activity kicks in her. She's like, it's like eating. She's like, I kind of know I'm eating, but it's not like I'm sitting here being mindful of my eating and my chewing, right? We don't think like that. That's way too much energy that would defeat the purpose of how we work in our brains. But for her, smoking really was centered on a lot of these conditional responses. So how do we manage such individuals? The big key thing here is listen to what they say. A lot of these individuals will discuss feeling weak. How can I be so naive? How can I feel why aren't I strong enough? You have to change that language, right? Because from their standpoint, this is part of motivational interviewing, where they're kind of trying to sabotage this plan. They want you to reaffirm their weakness. You are weak. You smoke. You can't do that. I'm so stressed out if I don't have a cigarette. I mean, like, come on, this isn't the right time. I just lost my job. Like, my husband's leaving me. Okay. This is a social version of them that wants to smoke. And waiting for them to have all the stars align really makes no sense, because that means you're only teaching them how to be a non-smoker during those moments. They need to understand that they need to be non-smokers in all social phenotypic versions of themselves. If they don't grasp that, they will always relapse, right? That's the conversations we need to have with these patients, and in an honest one. And yes, it may seem like it's going to take some time for them to become non-smokers, but the reality is they become non-smokers and rarely will they relapse. That's the big win. Because if we keep using the trivial word quitting, well, they'll report back to you, well, I've quit thousands of times, right? We use, if you take nothing away from me in this conversation, is to hopefully stop using the word quit. We've never defined it medically. There isn't one standard definition for it. And that's really not the goal that we try to explain to our patients, because quitting implies something very quick, very brief. Even if it needs a bit of duration, that should be permanent. And that's not the case, right? No other chronic disease do we say quit having it, quit having asthma, quit having coronary artery disease. You manage it, recognizing there's going to be highs and lows, but you try to minimize those lows. Same thing with us. This is a chronic disease. These patients will have these cravings for a cigarette permanently. It doesn't stop just because you told them to. You can't fear-mongering out of it, right? My favorite example that I'd like to share is 1/3 of patients who get lung transplanted, relapse to smoking within the first 6 months. 1/3. It's not fear. They have to just understand how cigarettes are introduced to their lives, that they want to explore it. So with these patients, the first thing that we do is introduce this concept of mindfulness. They have to be aware of their patterns of how they smoke. It won't capture the complete pattern in the first 4 weeks. No, we usually need about 6 months with these patients so we can kind of understand all their social phenotypes in good times, in normal times, in bad times, and in low times. And that's what I try to work with them, is each response for you is meant for something. Right. One of my favorite examples with this 48-year-old patient was her describing, those moments of her smoking in the context of her life. She cares for her elderly mother who lives in that home with her. She cares for a disabled child. Those moments of smoking, that's her respite. That's her kind of break for herself. The suddenness of when she realizes that's her reward. Now she can begin to figure out how to replace, not substitute, but how to work against that. She realized that reward is ultimately doing her harm, but she realized its purpose. That's what these patients have to work on, not only understanding their pattern, but the meaning behind it. And it might sound incredibly trivial, but once they start exploring it, they're like, yeah, I guess I do smoke when I'm stressed. And I've introduced that to myself since I was a kid. You find the same concept with a lot of youth who vape. They vape around tests. They vape around, peer usage. It's a conditional response that they've introduced to their lives. And you have to work with that. The pharmacotherapy is important, but none of these medications slap a cigarette out of their hands. They don't, and they won't. The purpose of the medications is almost like using it like a pain medication for someone after surgery, right? And you want to get them up out of bed and walk, that's fine. But in order to do that, they got to be pain-free. You want your patients to be able to say no to a cigarette, to begin to unsmoke. Well, give them a fighting chance. Attenuate the cravings intensity. These pharmacotherapeutic interventions can do that, from NRTs to bupropion to varenicline. They all work a little bit differently, sure. But at the end of the day, it's given the individual a fighting chance for an addiction that has been part of their life for more than 90%. And then what I mean here by harm reduction and harm removal is, again, I want to make them successful in this journey to become a non-smoker. There is no way a person, flip of a switch, can achieve that right off the bat. Don't set them up for failure. That's not fair to them. Again, think about it like a chronic disease. You have a patient coming in with blood pressure of 180 over 90. You're not going to say, all right, I'm going to give you these medications and in 3 months you're fixed. No. You reassess, you have touch points. Maybe they have a sphygmomanometer at their home and they have these touch points. As you wean, meaning as you reduce the harm of hypertension to ultimately removing it because you've gained control. That's what we do with chronic diseases. We always harm reduce until we can get them to that physiological phenotype that we want and say we finally got control. Now it's a new strategy to maintain that control. That's what we do with chronic diseases. So here we begin to wean off the cigarettes. Get them to win with each one. How did you say no to that one? How did you unsmoke with that one? Take those strategies and apply to much more difficult conditional responses, right? For a lot of these patients, that's where they look to see which cigarettes can I begin to unsmoke around and build new habits to continue carrying that on to the next one, to the next one, to the next one. And in that journey, they become non-smokers. That's the goal. That's what they want to achieve. They don't want to trivially quit. They want to know there's a permanence here where they know themselves. So it's harm reduction to harm removal, whether it's 2 cigarettes a day or 2 packs a day. We have the same approach, but again, we begin to make it more precise once the patient understands themselves a little bit more. So I'll stop there. That's my email for any questions you may have. I'll stop sharing a little bit short of 12:30, given our next speaker a little bit of 2 minutes of time. Michael, over to you.
Great. Thank you so much, Panagis. We do have a couple questions, so we can go ahead and jump into those real
Sure.
quick before moving on. The first question I think is related to one of your earlier slides, asking, does trauma complicate this link?
Sure. If you introduce cigarettes to that, of course it does. Cigarettes work on acetylcholine receptors of the mesolimbic cortical area of the brain. A lot of pathologies of mental health have the same action, right? We work with an outpatient psychiatric clinic creative alternative. A lot of those patients have schizoaffective disorder, schizophrenia as well. If you ask them how they smoke, they'll tell you they smoke to mitigate and blunt their hallucinations because that's where acetylcholine tends to work and be dysfunctional. And it does. Free-base nicotines are great reducer of these hallucinations, well studied. So trauma steals kind of that same platform for a lot of these mental health diseases. So if their smoking is around trauma, yeah, that's where sometimes you have to have these dual conversations with their therapist of saying, as you work on the trauma, I'm going to work on the tobacco dependence as well. You oftentimes need that dual relationship with their therapist. Again, not just for trauma, but for other psychiatric conditions and mental health concerns.
Great, thank you. Next question, instead of using the quitting or being quit terminology, what should we use instead from a cessation standpoint?
Yeah, and again, it's, smoking, tobacco dependence is the only disease that I've ever met that we never invited patients actually to give us input, right? If you go through cancer, you want to hear from the patient struggling with cancer. This is terminology that's created and made by people who've never smoked before. I use you want to become a non-smoker or be non-smoking, however they want to identify themselves, and they want to learn how to unsmoke. That's the verbiage I use, and that's verbiage that will resonate with them. The best compliment you can get out of these patients is that you must have been a smoker because you get it, right? We can't walk in the shoes of our patients, but use the science to walk by them. And that's what I plead, right? Quitting is such a trivial thing, right? Again, if you can give me a medical definition for it, then why are you advocating for it? Well, you know what you want out of these patients is to become a non-smoker or see themselves as non-smoking through unsmoking behavior. I can keep knocking out questions if that's all right with you, Michael.
Yeah, sure.
So Heather Grove, you wrote so many things set quit. Yeah. So the quit date, we haven't. So in the American Thoracic Society put out new guidelines, and we've kind of made it clear, like indirectly, you don't need a quit date. Again, treat this like any chronic disease. You don't. I've never had a patient with asthma. I'm saying this because we have a pediatric pulmonologist next saying, when do you want to stop wheezing? You don't say that to patients. There's no chronic disease like that, right? You can discuss, hey, we're going to begin to manage this as we get to know you, because it's kind of also a really odd thing to say, we know how your disease is going to go. No, you don't. Every patient who smokes has a different smoking phenotype and a different smoking topography. And if you don't understand that, and you won't, it's really kind of foolish to give you a quit date, because then if they feel that, then they're going to feel like I just feel all overall. I work with them as a chronic disease model over time, right? That's the respect that they deserve. All right, they deserve to be treated like any other patient with any other chronic disease. So from my standpoint, I don't put that out there. I work with them. They don't even have to reduce their smoking consumption with me. Sometimes our first strategy is just get used to the medications we're going to start. Make sure you can tolerate them well, right? Because they will build up. And then when they're ready to begin to wean, they'll be ready to go.
Great, thank you so much. I don't think we have any other questions at this point, but if any other questions come up, please put those in the chat and we will get to those later on. All right. Our next speaker is Dr. Nidhi Kotwal. Dr. Kotwal is a board-certified pediatric pulmonologist and assistant professor in the Department of Pediatrics at University of Maryland School of Medicine. She completed her medical school in Goa, India, and residency in pediatrics at Icahn School of Medicine in New York. She then went on to complete her pulmonology fellowship at Children's National Medical Center in DC. She's currently the director of outpatient bronchoscopies of the Division of Pulmonology and Allergy, University of Maryland. Her clinical and research interests lie in youth tobacco treatment and pulmonary disease in patients with sickle cell anemia. She's also actively involved in youth tobacco treatment in the clinical setting, as well as resident mentoring and leading community outreach efforts regarding tobacco and vaping. So the floor is yours, Dr. Kotwal. I can bring up your slides, or if you want to bring them up.
Thank you, Michael. I can bring them up. Yeah,
Okay.
share them now. Can everyone see them in presenter mode here?
Yes.
Okay, wonderful. Thank you, Dr. Galiasatos, for such a in-depth and a deeper meaning towards nicotine and tobacco. And I think, thank you for also bringing up that it's and equating it to chronic disease, because it's more of a tobacco treatment than it is a tobacco, quitting or cessation. So yeah, I think kind of just taking a small tangent off of that, but keeping the same basic thought process. I want to go over first the case scenario, and then we will talk about the clinical approach to vaping in the youth. And I'm talking about like 11 to say maximum 21-year-old patients here. So I want to bring up this case because it was fairly early in our journey towards starting youth tobacco treatment. And so I think kind of some lessons we learned through this, and also changes we've made as we've gone forward. So 17-year-old male presented basically with a history of depression in the past, presents with fever, respiratory distress, and abdominal pain. And this was in February of 2020 when he first came into an outside emergency room with fever, respiratory distress, and abdominal pain. He had got a chest X-ray, and he was disproportionately out of breath as in comparison to his chest X-ray, and hence was transferred to University of Maryland for further management. He was admitted because he was found to be hypoxemic, and then was started on 2 liters per minute oxygen. And this is what his chest X-ray looked like. You would look at it and you would say, okay, this is some increased interstitial markings out here. Yeah, looks a lot like a previously healthy patient, maybe looks like an atypical pneumonia. Let's treat him with a Z-Pak and a ceftriaxone. So he gets treated with those. Important to note, no causative organism was found in this. So this episode finishes, he is discharged 2 days later. He goes home and he's fine until October of 2020, when he comes back to the emergency room with, again, abdominal pain, hypoxia, and again, questionable pneumonia. Because he comes in with this much abdominal pain, which is mostly like upper quadrant, right and left upper quadrant abdominal pain, and is hypoxemic. They want to rule out this time a PE, pulmonary embolus, and so they do a CT scan of the chest, and this is what they find. So these 2 sections show that there is increased ground glass opacification on both lungs, very diffuse in pattern. We also see that on this section here, that there is this pattern called tree in bud, which was read as tree in bud pattern, which basically means that a branching tree pattern here with budding happening. And it is seen in certain conditions where, for the non-pulmonologists in the group, like certain conditions where you can have secretion deposition, some infections can lead to that, and some inhalation of fumes can also lead to certain similar pictures. But important to note that it's a very diffuse finding, right? He, at this point, is not hypoxemic, and so he's discharged because he feels better. He does not need, it's not a PE. He is clinically stable. He's given a follow-up with PCP in a couple of weeks. He does follow up. He's fine. and everything is fine until March 2021, when he comes back with cough, shortness of breath, and this time hypoxia again, requiring a PICU admission at UMS and then 15 liters high flow nasal cannula. So if you see, it's just worsening clinical presentations over time. To this point, he does have a left-sided pneumonia on this CT and is found to be rhinovirus positive. So yes, clearly he's treated for a pneumonia again, which is seen on the CT here, the left lower kind of pneumonia here. He also got an abdominal CT at that time, hence I only have the lower lung fields views here. But that abdominal CT was done to see if there's any other pathology going on. He was found to have some appendiceal thickening, which was deemed to be non-surgical. But this prompted people to take more history. And so there was more history that was obtained. And he said that, yeah, I have been getting sick from time to time. I feel like I get this fever, shortness of breath. I get on and off abdominal pain. Even when I'm well, I feel this way. And so someone asked him about history of vaping, and he said, yes, I have been vaping for 3 years. I vape daily. He actually also knew that there was 5% nicotine in there, approximately 2 years prior to the presentation. Started smoking marijuana also mid-2020. He had, of note, no previous history of asthma, no other history other than depression. And hence he was diagnosed after the 3rd episode with EVALI, which is e-cigarette vaping associated lung injury. And this is something that was new at that time. I think, at that point was the vaping, the epidemic. For those who know, around 2019 is when there was a peak in these EVALI cases in adolescents, and but then kind of was overshadowed by COVID, if you may, and then kind of did not come up as much in our discussions going forward. So then this patient was treated with prednisone taper, according to CDC guidelines, and then recovered. So based on this, I really wanted to encompass the symptoms because I'm purely looking at the case right now. I want to look at vaping associated symptoms. And if you look at them, they're very non-specific. They're, cough, chest pain, shortness of breath, abdominal pain, nausea, vomiting, diarrhea, fever, chills, weight loss, which this patient ended up having as well later, but kind of very constitutional, very overall symptoms, and which can be very much confused with a lot of other conditions that are happening. I did want to point to, hence, the definition of actual EVALI and what it was, and really a lot of words on this slide, but all it means is that what's common between the two is that e-cigarette was used 90 days before symptom onset, and there were pulmonary infiltrates that were seen that were diffuse and ground glass. The only difference is that there was infection. There was no evidence of infection in a confirmed case of EVALI, whereas in a probable case of EVALI, there was some infection, but doesn't totally explain the entire presentation, which was the patient in our case. I bring it up because it transitions well to the outpatient too. He ended up seeing us in the clinic after, and I'm going to walk you through this kind of timeline that he had. If you look at the March to July 2021, the one on the left, this was the first time he started coming into the clinic. We offered him some scoring tests, and he was able to tell us that he was low, he had low dependence to the vaping or tobacco at that time. He was not smoking cigarettes. He was just vaping and was also doing marijuana, but had on and off on the marijuana though. At that point, I think interestingly, he refused a nicotine patch. He also refused to take any treatments as such because he said he can, quote, do it himself. And I think that many adolescents, when I talk to them and we talk about their health and their imaging and everything they want to, and even some of them, they don't know about the effects of tobacco on their body. So when some education is provided, they are more willing than not to do it themselves and say, hey, I'm actually not addicted. I can do this myself. I can make it happen. And so you kind of, it's that little fine balance where you want to let them do and get that independence, but you also want to be around to help out and follow closely. So we were following him like every month to 2 months in this time, and he was not. He was saying he had actually stopped vaping. But by November 2021, he stopped vaping, but continued marijuana. In January 2022, he had some unintentional weight loss and stopped all inhalers for treatments that were given to him. So I will say, though, we did start him on certain asthma inhalers because his pulmonary function started dropping, and I'll bring you to that in a second. He did have persistent marijuana use and then ended up restarting vaping in August of 2022. This is also when he was going to start college, and there were more stressors. And at that point, we had a discussion about starting nicotine patch and gum just to have in case he were to have cravings. He said the next month that he had stopped vaping again and then was slowly transitioned to the adult side. This is what I have for this patient, but I mean, definitely there are things that I have learned through this that we can talk about as we go. In January 2022, we also got a repeat chest CT that, if you can see, showed resolution of most of the ground glass opacities, but there was some mild bronchial wall thickening and some air trapping, which was also evident on his pulmonary function testing. If you can see, as time goes, his FEV1 to FVC ratio dropped from March of 2021 to July and January of 2022. Even though the CT looked better, he was still having symptoms that were related to dyspnea. With exercise, his FEV1 and FVC ratio was going down significantly, and he was showing obstruction. So he was started on asthma medications or inhalers. He also ended up getting a bronchoscopy, which had a normal anatomy, but we saw a lot of findings that we see in patients who do vape. We do see an increase of lipid-laden macrophages, but nothing that came up as completely abnormal if you look at these images. So I wanted to spend the next, say, 10 minutes or so kind of just talking about patient encounters for youth vaping. And I wanted to start with, I think, more practical, just clinical, day-to-day clinic. What can you add in your clinic to screen for vaping use, and how can you start conversations with these patients, right? I think many times what we all as providers really do well with our, like we talked about chronic diseases, or this is a disease, I need to treat it kind of thing. But then nicotine and tobacco and drug abuse somehow just falls on the side. And this is such a major part of our society, and how we see this is the youth that's going to develop as adults, and they can be smokers or non-smokers, so it's important to intervene now. And screening is number one. I think I want to really put into mind of us pediatricians is that, like Dr. G said, it's actually, vaping starts very early, like 11 years old. And American Academy of Pediatrics right now recommends that we start screening at age 11. As little as that seems, yes, that is the time when kids really get in touch with all these products out there. So I asked them basic screening tools. There's a craft questionnaire that's available. I'm going to give you examples of 3 or 4 screening tools out here. You can pick which one you like. There are some that are easier and less time consuming than others. There's the craft questionnaire, which is sort of like the cage questionnaire for alcohol. And pretty much like, do you use it in the car? Have you used it to relax? Have you used it when you were alone? Do you ever forget things when you use it? Or have your friends and family told you that you should stop? Or have you gotten into trouble using it? And the 4 questions here is like just a offshoot to this craft questionnaire. And here, question number 4 kind of asks about vaping products. And if the answer is anything other than 0, it pretty much directs you to the Hooked on Nicotine checklist, which is this one. So it basically is a yes and no questionnaire. And if any degree of yeses from 0 to 10 show that the patient has lost some sort of autonomy on their smoking or vaping. And so really what it comes down to is screening starting at 11. If not smoking, it's important to provide encouragement for that choice, because it is amazing when the joy on their faces you see when you congratulate them for doing something or not doing something that is being done everywhere around them, like their school, their kids, the kids around them in school, or their parents maybe in some cases are vaping all the time and they are not. And so it's important to point it out to them and say, good, congratulations for making this good choice. Let's check in again in 3 months when we talk about everything else, or just otherwise. And so that's important too. But if they are vaping or using tobacco, at that point, we offer certain questionnaires to assess the level of their dependence. So this is where I start offering the, these tests that we're talking about. Another one is the Penn State e-cigarette dependence index, which is only for adolescents. And it tells you the amount of dependence, and it's actually good because you can tell them that this is your score and they can score this every time they come. And then they now know, okay, I'm not medium dependence, I'm low dependence. Again, I don't know if that's the best way out there. There definitely are better ways to, show to them that what they're doing is right. But this is just a semi-objective way for them to assess themselves. Then we have the modified FTQ questionnaire, which is modified from the adult side, but it's mostly also showing the amount of dependence for the adolescents. I really like this one a lot too. It is an app that is developed by the American Academy of Pediatrics. And it is basically, if you go into the AAP website and just type the tobacco cessation app, you'll see there's ask, counsel, treat model. You have to just answer these questions. And as you answer, it gives you how much dependent the patient is, and then what can they do for that. So start instructions, they give you starting instructions of 14 or 21 milligram of patch. And I feel like this is important for pediatricians because number one, FDA hasn't approved NRT for patients under 18. So then there's always this question whether, am I supposed to do this? Am I not supposed to do this? Is this okay? What should I start with? It gives you instructions right there. So that's very helpful, I think. And so I really wanted to touch upon the basic elements of tobacco and vaping in a patient. And I think really this is less of a history taking or information gathering, but more of having a conversation and discussion. And the number one thing you want to talk about is use. What do you use? When someone brings up this on the questionnaire that yes, they are vaping, well, then I start asking them in the clinic, how much do you use? What do you use? Do you know what's in the device that you're using? Do you have the device on you? Can I see it? I try to be a little more curious about it so that I am trying to get to the same page as the adolescent and trying to understand what their routine around use looks like. I'm asking them about anybody else who's smoking in the house, or around what scenarios they're smoking. Have they tried quitting? Again, quitting is not the best word, and 100%, I think we try to steer away from it as much as possible, but they're trying to talk about past cessation attempts and timing of it and what was used. Like, did you have help? Were your parents there too? Was your sibling involved too? That kind of thing. The psychiatric history, extremely important, trying to assess their stress level. They're going through so much during this time, let alone, having one more thing to deal with. So I think definitely talking about that helps. Substance abuse, other drugs that are involved in their life, or, other environmental triggers and other smokers like we talked about. So this kind of mostly encompasses the information that I would like to get from them in their first visit. And as time goes on, I'll expand on this. And then just have a discussion with the adolescent. I think really it all boils down to how does an adolescent brain work, which is so much different than an adult brain. The biology of nicotine is same everywhere, only a little more, it's just a little easier for the adolescent to get attracted to that than an adult. And that's because of their, the amount of connections they're making, the neuroplasticity in their brain. But I would argue that along the same idea, I can say that it's maybe easier to intervene at this age than it is when these connections have been well established already, which I feel like our adult colleagues have a much harder job on their hand. And I think the more we do from a pediatric standpoint, the more we can try and make a difference. So I really try to ensure privacy for the patient, try to get the siblings and parents out of the room, number one. Then I say everything that we talk is going to be confidential. Would you like to tell me anything about all this? And then they start talking. And when they start talking, you let them be themselves. You show interest and you suspend the judgment. I think it's all about just the understanding that the evil here is the biology of how nicotine acts on the brain rather than the patient themselves. And many a times the patients are very sensitive to judgment in this case. So trying to refrain from any scare tactics or moral judgment in adolescence especially is extremely important. So basically it boils down to two things: being clear and letting them know that they're worried, that you're worried about them. And then saying things like, I'm really concerned about you. I really strongly advise, but let's talk about it. And emphasizing on the health effects as well. I think your brain is still developing, which means you can get addicted more easily. Can we talk about it a little more? Some messages that do resonate with them is not some, so I think what resonates with them more is when we talk about the immediate impact, which is let's talk about, how it'll affect your athletic performance tomorrow versus cancer in 50 years. They don't care about that part, but they will care about how they perform tomorrow. So I think I have had some success talking to them about athletic performance and dealing with that. Sometimes expensive e-cigarettes, how do you afford this? Well, you could have done, I think just reframing their ideas and then helping them create that divide themselves in their thought process. And then tobacco industry, how it kind of tries to market to the adolescent and explaining it to them, because there's a reason why all these vape shops are around schools, because they're trying to attract the teens. And so I think sometimes they need to hear it from someone. And then reasons for not using combustible cigarettes and linking it to the e-cigarette use. Many a times they don't know, they're so naive. They don't even, first of all, maybe they don't even know that there's nicotine in there, but at the same time, they know that cigarettes are bad, but they don't know that e-cigarettes are not that much better. So I think just linking them, the similarities between the two sometimes helps as well. And really, once we've talked about the counseling part, which includes motivational interviewing, that is empathy, accepting the ambivalence that they have, understanding their point of view, and kind of saying it to them, yeah, I understand that this is the time when you can get really stressed. And really, at that point, yes, vape seems to be the only way out. But have you tried something like this or that? Or, can we think about maybe some other strategies that would be helpful? Developing that discrepancy and helping them see that by themselves so that they can be in charge of their behavior change than us. Avoiding argumentation, not getting to the point where you're becoming the, for lack of a better word, like patriarchal in that one patient-doctor relationship. You don't want that assertiveness to happen. You still have to roll with their resistance, reframe their statements, and invite them to consider some alternatives. And always, always, always offer support. Really just have them build their own why. Pharmacotherapy, again, is not FDA approved, and that's what I want all of us to take away. But at the same time, it is still recommended for patients who are moderately or severely addicted to nicotine. And I think at this point, we start using it for them. And here, this is the forms of NRT we have in the adolescents groups that I have at least tried in the past. Varenicline is approved above 16, but the use is extremely limited in our patients. And this is just another guide that I wanted to show you for the NRT use. This is all available on the AAP website. it's also important to talk to parents who use tobacco and kind of trying to, you have kind of a double patient right there. Like, you have the patient, but you also have the parent who's also smoking many a times. So I think talking to them about how about we try to reduce our own smoking. And then I also sometimes refer them to tobacco treatment programs in the adult side so the parents can get help. And if they can, the biggest thing I ask them to do is try to keep it away from your children. Keep it locked, out of reach of children and adolescents. You don't want them to start something, and many a times they are more than open to this. I give them certain resources. This is just, I have it with me if they would need it. Sometimes it's always helpful to do this in addition to the NRT that we are also giving. And last slide here would be clinical documentation. So when I am talking, in addition to my regular E&M code, I am also using the 99406 and 407 codes for vaping and smoking cessation counseling. And they are both time-based, but it's important to note that if you're counseling the parent, then you cannot use that under the child, and vice versa. So, it's important to just be very patient-specific in here. So that was all in a small, very short context of vaping. I'm open to questions, and always please email me if you have any questions in addition to this. Stop sharing my slides.
Great. Thank you so much, Dr. Cotwell.
Of course, I can.
Let's see. So we have two questions. The first is, can you elaborate for practitioners in relation to prescribing NRT for children, considering a scenario where a school nurse might find a patch on a patient while they're being evaluated for something else? How do they reinforce the tobacco treatment message?
Okay, yes. Good. That's a great question. So so this is in perspective from a school nurse as to how she can, this is how I understand it, is that when this is a school nurse trying to help out and trying to see how they can reinforce the message. Yes, so I think that is a great question. So one thing we can definitely do is like look, when you notice it, you say that, I see that you have a patch here. If you know this is related, if this is NRT and you're 100% sure that that's a patch for the NRT, you can bring it up to them and you can say, is this NRT? Oh, I see that you're using a patch. Great job on using this. Is there anything, if there is anything I can do to help with this, please let me know. Many a times we will provide letters to schools if we are prescribing the NRT to the patient. And so hence it'll go with the letter. So they already know that that's happening. The school nurses will have a letter. But if that's not the case, you can definitely bring it up and encourage the use of that, and then offer assistance, and also let us know if you see something that is off, like, yeah, I'm using it, but it's really not working, or I would like to just, I don't know why they gave it to me. It can be different scenarios or different things that adolescents bring up. They may say, yeah, I just put it on because my parent asked me to. I really don't think it's working. Well, then why do you think it's not working? Is there anything we can do to help, or can I reach out to your doctor? And I appreciate those messages if we get it from school nurses. Yes, any information we can get, we try to follow them every 2 weeks. But even in between, if there's anything, we're more than happy to reinforce the message ourselves as well.
Great.
Does that answer? Yeah.
There's another question. So how do you address misinformation about NRT from adolescents? A teen the other day believed patches to be just as bad or worse than cigarettes and vapes because of the nicotine. Would you explain it to them similar to how you would debunk a myth from an adult?
Yes. So I tell them that, yes, we're giving you nicotine and nicotine is not bad. The way nicotine is given makes all the difference. So what I try to explain it to them is that a cigarette will give you phases of nicotine. Like, it's going to give you that up and then it's going to give you that down and up and down. Whereas an NRT is going to give you a tonic delivery. It's just going to give you that little amount of nicotine that's in your body that's just going to prevent that extra craving from happening. And then there are a small amount that's also given for cravings, but it's acting very differently on your brain than your phasic cigarettes or vaping that's happening. So I do try to explain it that way to them.
And if I can jump in and add to
Yes,
that,
please.
right? Because I think there's an unfairness of villainizing nicotine. Nicotine in its natural form, right? And this is how I had great discussion there, Dr. Cotwell. What I add is if you eat one eggplant, you've ingested as much nicotine as 2 hours of secondhand smoke. Nicotine in its natural form, the way it's also given by NRTs, is not addicting, right? It's like eating grapes and expecting to be drunk, right? Grapes aren't wine. They have to go through a chemical process in order to exploit the ability after fermentation and maceration to become wine. Eating wheat doesn't make you drunk. If you want that barley to become beer, you understand it's got to go through very specific processes. The reason why tobacco goes through fire, heat, or in electronic cigarettes, the heating coil, is to demethylate it. Once it's demethylated, suddenly now you have a free-base nicotine that can begin to hijack that addiction. Chewing tobacco utilizes the same concept through enzymes that were added into it through, I think they're fungi derived, but they got to demethylate it. Once it's demethylated, now you have an addictive product. That's what I try to explain to patients, right? These tobacco products introduce it chemically enhanced to exploit the addictive property. And as Dr. Cotwell mentioned, in a way that can't be replicated, right? You inhale it to the lungs, to the circulation, to the heart, squeeze to the brain. All the NRT products enter through the venous return system, right? Then they're metabolized by the liver. That nicotine barely gets to the brain. Usually its byproducts get there in order to kind of offset the craving, as Dr. Cotwell mentioned. Our NRTs are not substitutes for vaping or for combustible cigarettes. They are not. We're using nicotine in more of a therapeutic approach to offset the cravings. Nicotine by tobacco companies massively exploits the addictive potential. It is very different. And so that's what I try to drive home. Grapes versus wine, barley versus beer, right? Innocent fruits and vegetables, alcohol products, right? That's the big dichotomy there that we need to make sure we drive home.
If I could just jump in for just a second. So maybe this NRT use in children is very, very new. I wonder if you could just pull up that AAP tool again and just walk us all through it, because I think a lot of us knew it was out there, but I'd never seen it. So
let me bring it up in real time here. 1 second. AAP. Okay. And I'll share my screen in a second. Okay, so here. Can you all see my screen, the cessation app here?
Yes.
So I just typed tobacco control. So I just typed AAP tobacco cessation app, and then you just click access tool. And when you do that, it gives you, has the patient been identified as tobacco products, e-cigarettes or cigarettes? And if you say, for example, I say yes, it's going to ask me, are they interested in making a quit attempt? And I say yes. Well, then 4 questions come up. And I'm just going to pick up some options here. Have they tried without thinking about it? Well, sometimes. And then next, it gives you resources. But then it'll also give you, hey, for now, just it's going to say assess progress in 2 weeks, and you can do it by in-person, phone, or telehealth. So this is one of the scenarios. If I pick, for example, the severe one, so almost always, it'll give you severe dependency. It gives you, for best results, you pair NRT with a short-acting lozenge. It'll give you instructions for use of the lozenge and instructions for use of the NRT. And it tells you start with a 21 patch and then step down. How do you step down? And the side effects with it. And then the links to behavioral support, and then follow-up. So it's, yeah, I think for a busy pediatrician, it's very helpful to just have this, because many times we don't go into all the references and look at it up in a busy clinic.
Thank you. If anyone else has questions, please enter those into the chat for us. I do have a question myself, and
Yes.
both of you kind of touched on this. There's lots of different options in terms of treatment. You can go to primary care, you could go to a mental health or addiction counselor, you could participate in a program like Freedom from Smoking. Is there a best starting point for someone who's looking at treatment? Should they consider all options, or where do they begin?
I'll start first. They begin with whatever trusted clinician, whether it's primary care, mental health, sometimes a sabotage strategy is, oh, I need to get into them. So until I get into them, I can't do it. And then suddenly they keep delaying and so forth. Wherever they, I mean, it could be the school nurse, wherever there's a trusted individual. And tobacco dependence, in all fairness, shouldn't be just managed by one person. It should be managed by a person who can reach out to everyone else on their team in order to pull this together, just like you do with a chronic disease, right? My pediatric pulmonologist friend, probably while she manages asthma, she makes sure the parents are aware of how to manage their asthma, touches base with the school nurses. It's a village around this aspect. So I would say wherever they can get that trusted clinician to begin the conversation, but carry it to others as well. Dr. Cotwell, if you want to dive.
I agree. No, thank you. I think, yes, I assess in the first visit as to what does the teenager want from me. I'm trying to assess, hey, can I help you? First, can I help you with this? Do you realize yourself that this is something that we are also dealing with? Because many times they're like, I'm just here for my asthma clearance. I want to get into military. Can you just clear me for my asthma? I don't have asthma. And then I'm looking at their smoking or vaping history, and then we're talking about this, and it's completely different from what they came in for. So I want to first assess as to, are we on the same page here? Am I thinking what you're thinking? And if not, can we have another visit in a week or two to just talk about this? Because even if in the first visit, I can even get to their attention that they're doing this more than, anybody else has never brought it up to them, then that for them is a big reveal. And I think they need time to process this. And then a week or two later, we try to get in touch with them. For right now, I'm trying to get in touch with them through a tele-ask service through our adult pulmonary team as well. So they're very helpful in getting patients on the phone after 2 weeks. And then we try to get them in again in a tele-visit in 2 weeks later. So we try to get them at 2-week window. And we say, and then it did actually happen one time when I asked them something, and 2 weeks later, the patient came on the tele-visit with me, and I said, hey, do you know why you're here today? Yes, doctor, we're going to talk about my vaping. And I thought that was a success because she brought it up as I'm going to talk about our vaping. And so I think from then on, I thought, okay, I can get somewhere. Because before that, I could just be talking to the walls. No one's they're gonna say yes and leave the room. So I think that's one. And then the resources for quitting, I think they're all there, and I know they can look it up. I don't have handouts that I give them. I say, hey, I have a text-based service, but they're gonna text you left, right, and center. So just, that's something that you need to be aware of. There is a quit line, and I try to ask parents if they've used any of these and have had success with it. And if not, I give them the option to pick what they want to pick. But then I keep going over it again and again.
Thank you.
Yeah.
I don't see any additional questions at this time. Oh, there's one new one. Can you talk more about NRT for a patient, adult or youth that has never used it before? What do you tell them to expect?
Okay, I can talk about the youth one. So for the patch, I tell them skin irritation is a big side effect of this. Most of them are open to the patch first. I have not personally used varenicline, but I know they have some sleep disturbances, but I have not used it, so I will not speak to that. But there is the patch part, there's the skin irritants. So if that's the case, I tell them to start using hydrocortisone and switch out the patch spot. but do not ever take off the patch, even if you are vaping along with it. So I tell them that. And then for the gum and the lozenge, we talk about some side effects as well, like, irritation, funny smell or tastes that can happen, and with both of them. So it's limited. Our use of NRT is still limited for us. But I'll let Dr. G.
Yeah, no, great points. I also make it clear, this cannot be a passive activity, right? The patch is not gonna, no one's gonna put on the patch and feel like I'm having a cigarette. That's not how the patch works, as we discussed earlier. The patch isn't gonna slap the cigarette out of their hand, right? So I get many patients that'll come and like, oh, the patch didn't work. Why didn't it work? I still smoke. Okay, were you counseled on what to expect? I mean, other than the side effects, as Dr. Cotwell mentioned, you have to make sure they understand the expectations. Unless they are actively using mindfulness to be able to harm reduce, ultimately harm removal, they won't understand that the patch and how it works. So you really got to prepare them. You're going to have to put in the effort, right? Again, it's like taking a pain med after a knee replacement. The patient's got to get up and walk, or the knee replacement went, it's the efficacy went away. They got to get up and walk. It's going to hurt, so they take a pain med, but they got to get up and walk. They got to learn how to unsmoke. They'll take the NRTs to make it easier. That's the goal. You want to reduce these cravings, but they got to still put in the work. So great job. You got to prepare them for the side effects, because if they're not aware of it, they're going to just, that will sabotage it. It irritated me. I'm throwing it away. I had bad dreams. I'm throwing it away. You got to prepare them. And duality of, you got to make it clear that this is not a passive conversation, right? They got to put in the work to learn how to unsmoke. You can't expect that just from the NRT alone. And I'm saying this because I get so many who come and say the patch didn't work. So what didn't work about it? I still wanted a cigarette after 3 days. And you will. You always want a cigarette. That's not how it works. So same conversation that you want to be able to kind of get to them.
Great. Thank you so much. I don't see any new questions at this point. So again, thank you to Dr. Cotwell and Dr. Galiasatos for being with us today. I do have one other thing to go over before we come to an end. If I can get that up. As a reminder, our recording and our slides will be up on our website. This is the link here. They'll be under the trainings tab, past presentations. You can also find on our calendar our upcoming webinars. Our next webinar is on October 30th at noon. This will be a cannabis fireside chat with Matthew Spinburn from the University of Maryland School of Law. There's a registration link here. It's also on our website. I do encourage you to go ahead and register for that. There will not be any CME or CEUs for that session, but it should be a very interesting session. Matthew is a great presenter, so I definitely encourage you to all join us. And then again, thank you to our speakers and our sponsor, Maryland Department of Health. Attendance certificates will be sent by email. Again, please complete the evaluation. The link is in the chat. The QR code is here as well. We value your feedback. It really helps us make improvements and learn about what you're interested in hearing from us as we plan future training sessions. So thank you again to everybody. And that will bring us to the end of today's session.
Thank you, Michael.